Here's an example of a couple of MRI images, and this is actually our daughter's MRI. So if you look at this white patch here, this is the image is flipped, so on the right side, this is what the doctors referred to as abnormal white matter lesions, and this is just one slice of the MRI. So this is the left half of the brain, this is the right half of the brain. This dark area in the middle is the white matter, and this area around the outside is the gray matter. But slice after slice after slice, she had this big white blotch. Again, they didn't know how or why or when it got there. All they knew is that the seizure started from that abnormal area. Now, a couple, 3 years into having seizures, this is what her MRI looked like. Now, this is a slice of the gray matter. And you can see, I'll move my mouse here so you can see, but you see these black areas in between the brain tissue. This is what the doctors refer to as atrophy. So this is where they told us that our daughter's right side of her brain was shrinking and disappearing, and they didn't know why, and there was no way of stopping it. So we were told at this point that we were losing our daughter cognitively as well as physically. Some people with epilepsy live with co-occurring disorders. Approximately 25 to 30% of people with an intellectual disability will also have epilepsy. You look at individuals on the autism spectrum, a certain percentage of them have a form of epilepsy. 27 to 65% have EEG abnormalities. And there was some research done a couple years ago from Boston Children's Hospital that is now showing 40 to 45% with individuals living on the autism spectrum also have a co-occurring condition with epilepsy. You look at individuals with cerebral palsy, they're at higher risk for epilepsy. And if they have a co-occurring condition with an intellectual disability and cerebral palsy, the professionals are saying over 50% will also have epilepsy. Even ADHD is seen in up to 40% of children with epilepsy. Basically, if an individual has neuro or neurological challenges, they're going to be at greater risk for potentially developing epilepsy or having seizures down the road. What are some possible triggers or precipitants to epilepsy? Well, a lot of people are familiar with flashing lights and hyperventilation, which can trigger seizures in some folks. Now, the nice thing about flashing lights is when individuals go to see a neurologist for basic diagnostic testing, one of the basic diagnostic testing that they do is a 2 to 4 hour video EEG. They put electrodes on the head and they monitor the brain waves when the individual is asleep as well as awake. And they'll flash the lights in front of the person's eyes and they'll watch that monitor to see if there's a response. So if you know any individuals or you work with any individuals where lights are a trigger, some things that you need to keep in mind are, you know, if they're going to a rec center, the lights in the gymnasium could trigger potentially seizures. Or people describe to me when they're sitting in a car or in a van and the light shines through a window a certain way, it could potentially trigger a seizure. Or even computer screens or certain video games that are fast-paced that have those seizure warnings on them. Or what about emergency protocol? I was in a hospital the other day, and not only was the sound going, but the lights were flashing everywhere, for people who were deaf impaired. And that's a potential trigger for people with epilepsy. Other factors that might increase the likelihood of a seizure in people with epilepsy include missed or late medication, and that is the #1 reason for potential breakthrough seizures in individuals. People living with epilepsy need their medication on time, every time. Stress and anxiety is another potential trigger. A lot of college students say the week of finals, they're so stressed out with increased anxiety, they can feel seizures coming on and have breakthrough seizures. For other individuals, it's lack of sleep or fatigue. People describe to me they need the same number of sleep every night. If they have too little or too much, they feel ripe for having seizures the next day. Hormonal changes, those females, if it's that when it hits that certain time of the month for their menstrual cycle, they're having seizures. And that's another area that's not very well understood in the professional amongst the neurologists. When somebody is ill or sick, their seizure threshold is lower. They're more likely to potentially have breakthrough seizures. If an individual is drinking alcohol or doing drugs, they're at greater risk. Or even drug interactions. The doctor could prescribe an antibiotic and it could potentially interact with their seizure medications. Overheating and overexertion. This one was a big one for my daughter. We would often get the call from school during recess or PE. As soon as she started working up a sweat, she would be going into major seizures. Poor diet and missed meals. Like most people, it's important to have a healthy, regular diet. Some seizure medications you need to eat on a full stomach. So if that child is going to school and getting that noontime dose at school, you need to make sure that your child is getting her food, is eating food at that lunchtime meal, if she needs to have that medication on a full stomach. The extreme heat and the extreme cold. Adults who are waiting at bus stops in this extreme weather are potentially likely to have breakthrough seizures. I know people that can't swim in the summer because it's so hot outside, and the contrast with the cold water, going into that water, they potentially have seizures. Now, you may know all the person's potential triggers and avoid them, and it's important for you to know they still could be having seizures. And that's what happened with our daughter. We knew some of the triggers, and we tried to avoid them as best we could, but she would still be having seizures anyway. But there's things you can do to avoid the triggers to help make that person safer. So there's two types of seizures. There's the generalized seizures and the partial seizures. When somebody's in a generalized seizure, that involves the entire brain. Some common types include the absence and the tonic-clonic. Symptoms may include the convulsions, staring, muscle spasms, and the falls or drops to the ground. Whereas somebody that has a partial seizure, it only involves part of the brain. And these include the simple partial and the complex partial. And the symptoms relate to the part of the brain affected. For example, if it's just the motor strip affected in the brain, on the right side of the brain, it could be that left arm, a jerking and a going. So the first type of seizure I'll talk about is the absence seizures. These are generally known as those quick staring spells. And it can be very difficult to recognize. What this type of seizure looks like is that there is a pause in activity with a blank stare, a brief lapse of awareness. Sometimes there's possible chewing motion with the mouth or blinking motion with the eyes. It lasts relatively pretty brief, around 1 to 10 seconds. It may occur many times during a day. Many people I know, they have hundreds of these a day if they're uncontrolled. This type of seizure may be confused with the person daydreaming, lack of attention, or even attention deficit disorder. Sometimes this type of seizure is picked up on in the school environment, in that structured setting by that teacher. One of the things you can do, which can be difficult to have an idea if a person is daydreaming or not, is to say their name and to see if they respond. A lot of times with people are daydreaming, they will snap right out of it and focus back to task. But oftentimes a person in an absence seizure won't snap out of it until 1 to 10 seconds. The other thing with the absence seizure is generally the individuals don't remember what occurred during that event. They're, like, for example, if they're at work or they're in a classroom environment, they're listening to instruction, they're checked out for a few seconds, then they're right back with you. And they just kind of look around and pick up right where they left off. Now I'm going to show a brief video clip of an absence seizure.
Can also be on the other side of the coin, what we used to call pattymall, where all we're seeing is an absence of a person. They just go blank for a moment, stare off, maybe a little bit of movement. And so we have this huge...
So that is an example of what absence seizure looks like. It's also important for you to know that the absence seizure is a generalized seizure, and the entire brain is affected when that person is in that event. Now, another type of generalized seizure is the tonic-clonic. When most people hear the term of epilepsy, this is the type of seizure most people think about. This is formally known as the grand mal seizure, but technically the term is called generalized tonic-clonic. What this seizure looks like is it begins with a sudden and hoarse cry. The person has a loss of consciousness and they will fall to the ground. Oftentimes it's with no warning. Other times they may feel that seizure coming on and then it'll go into a generalized tonic-clonic seizure. Sometimes with our daughter, she would walk real slowly and then she would go straight into a generalized tonic-clonic seizure. But most of the time I could sit right next to her or stand right by her and we'd be talking and walking, and it would happen so quickly. I would reach out my arms and most of the time I was not quick enough to catch her. This type of seizure has a lot of convulsions, a lot of stiffening of the arms and legs, followed by rhythmic jerking. Oftentimes there can be shallow breathing and drooling may occur out of the mouth. This is the type of seizure where there's possible loss of bowel or bladder control. Occasionally the skin, nails, lips may turn blue. You often don't hear this happening, but it can happen. And it did happen with my daughter. Her lips would turn a bluish purplish color, and it was a very scary thing to witness. Early on, we thought we had lost her several times because her eyes would shut and it was just like she was gone. But if I listened real closely, she was breathing. It was just very shallow. Generally, this type of seizure lasts 1 to 3 minutes. But I'm telling you, if you've ever witnessed a generalized tonic-clonic seizure, it seems like it lasts forever. When the person comes out of this event, they're usually very confused, they have a headache, they're tired, their muscles are sore, they could have difficulty talking. Our daughter could not walk, her left side was just gone. We would literally have to pick her up and take her to her room, and for her case, she would need 2 to 4 hours to rest and recovery. If we prematurely woke her up because we needed to go somewhere, she was still out of it. It's almost like the brain knows when it needs to reset itself, how much recovery time it needs. And the recovery time is different for everybody. Some adults I know, they have one generalized tonic-clonic seizure and they can't go to work for 3, 4, or 5 days. It takes them that long to recover from one of these events. Again, the recovery time is different for everybody. I have 3 different video clips I'm going to show. They're just brief video clips of what the tonic-clonic seizure looks like.
Seizures, and that's the tonic-clonic seizure, or we used to call the grand mal.
Okay, so that was one video clip, and I'll pull up the second one.
How can a bystander help? First, let's look at the tonic-clonic seizure, where a person is unconscious and convulsing.
So a lot of jerking and shaking motion with the limbs. I'll pull up the last one. This last slide, you'll see some saliva coming out of the mouth.
Sort of put them on their side, and so that liquid coming out of their mouth goes out of their mouth, drains, and it doesn't go into their lungs, which would create another problem.
Okay, so those were 3 very brief video clips of the tonic-clonic seizure. So what do you do if you see somebody in a tonic-clonic seizure? It's very important to stay calm and track the time. If you're out in the community and it's somebody that you don't know, check for an epilepsy or seizure disorder ID bracelet or necklace. Protect the person from possible hazards. You want to move the chairs, tables, sharp objects out of the way, so as their limbs and arms and legs are jerking and shaking, they don't hit hard objects. We recommend training the person on their side, preferably on their left side, because that's the way that the heart is positioned and it helps for easier breathing. But we do not want the person on their back because they're at risk for aspirating or choking on the saliva. And we turn them on their side so that saliva can drain out of the side of their mouth. It's important to cushion their head. Their head's going to be going pretty hard. You're probably not going to have a pillow in your room, but you may put a pillow under their head if you have one. If not, use your hands. Oftentimes I had to use my hands under my daughter's head because there was nothing else around. If there's a coat or a sweater, whatever you can find, cushion the head. After the seizure, remain with the person until awareness of the surroundings is fully regained. Provide emotional support. People during a tonic-clonic seizure do not remember what happened. They come out of it, they could be crying, they could have a headache, Um, it's very fearful when you wake up from a seizure and people notice their friends or peers or coworkers staring at them, witnessing this major event. And it's important to document seizure activity so that individual or the individual's caregivers can provide that information to the neurologist to perhaps adjust some potential treatment options. Now, when a person comes out of a seizure, it's called the postictal stage. So I'm going to show a couple video clips of what that recovery time right after a seizure looks like. When you're timing in a seizure, we do not count the postictal stage during the timing. So I'm going to pull up the first video clip here of the postictal stage after a seizure.
In calculating the 5 minutes, keep in mind there's always a period following a convulsion where the person is unconscious or extremely groggy. This is known as the postictal stage, and this time period is not included in the 5-minute calculation.
I'm going to pull up the second video here of the postictal stage.
Seizure is going on and you need to call medical services. You need to be there reorienting the individual.
So those are just a couple brief visuals of what the postictal stage looks like.
Okay, this is June with the Brain Injury Alliance. It sounds like we are having some technical difficulties, so if you could just be patient just for one moment, I'm going to see if we can get Roxanne back. So just one moment here. Okay, it still looks like we're having some technical difficulties here. We're going to try to give Roxanne a call on the phone to see if we can reconnect her. Again, sorry for the inconvenience here. If you can give us a few more minutes and we'll try to reconnect her. She's got some really great information here, so we'd like to still try to get through to her. So if you can give us just a few more minutes and we'll see what we can get. Thank you. Okay, still apologize for the technical difficulties. We're having trouble getting Roxanne back on um, due to those difficulties. Um, if you are not aware, we will have the webinar archived on our website. So if you do need to log off and don't want to wait, please feel free to log off, and you can certainly join at a later time.
Yep,
And
June. Hey, June. It sounds like Roxanne has logged back on if folks are interested in waiting at all.
oh, it looks like she is back on.
Yes.
Okay, I
We're
will.
trying to get her audio up and running here. So let me, okay, Roxanne?
Yes.
Okay, I'm gonna let you go on the phone. Okay,
All right. Am I back up and running?
yes.
Yes.
All right. Sorry about that, everyone. I have no idea what happened when the computer shut down. So we will continue on. We just got done showing a couple video clips of the post-ictal stage after the seizures. Here's a picture of my daughter wearing a seizure helmet. So a seizure helmet is often worn for individuals as a safety measure to protect the head from injuries during drop seizures. What do you do if somebody has a convulsive seizure in a wheelchair? Do not remove from the wheelchair unless absolutely necessary. It's important to secure the wheelchair wheels to prevent movement. Oftentimes people will have a seat belt fastened, but you just want to keep it fastened, but loosen it up a little bit to prevent the person from falling out of the wheelchair. It's important to protect and support the head with some blankets or coats or whatever you can. So as their arms and limbs are jerking and shaking, it doesn't hit that hard surface of that chair. Ensure the breathing is unobstructed and allow secretions to flow from the side of the mouth. Pad the wheelchair to prevent injuries to limbs, and then follow the relevant seizure first aid protocol for that individual. So what do you do if you're transporting somebody to an outing, if you're an agency or if the child is on a school bus? Well, we recommend that it's important for the driver to safely pull over and stop the bus, and to place the person on his or her side across the seat, facing away from the seat. This is because we want to keep that airway open. It's important to follow the standard seizure first aid protocol until the seizure stops and the person regains consciousness. And then the bus driving company or the organization or school, they'll have their own policies of what to do in the situation as well, which will need to be followed. So what do you do if somebody has a convulsive seizure in the water? This is very scary. It happened to us twice. The first time was during private swim lessons. I looked up and our daughter was face down in the water. The second time, we just wanted to take her to the local public pool. We went on a 77-degree day, not too hot, not too cold, and she hunched over the side of the pool. Unfortunately, I forgot our rescue medication, the Diastat, that trip, and the seizure went on for 22 minutes. We ended up in the emergency room. If somebody has a seizure in the water, it may take a couple people, especially if that individual is big. It's important to support the head so both the mouth and nose are always above the water, which can be very difficult to do if that body is jerking and shaking. As soon as it's safe to do so, remove the person from the water. If the person is not breathing, that would be the one time the medical professionals recommend rescue breathing. But always, always transport the person to the emergency room, even if they appear all right, because you just don't know how much water they could have potentially taken in. So some dangerous first aid is never ever put anything in the person's mouth during a seizure. Do not hold down or restrain the person. There's nothing you can do by holding their limbs down to make that person come out of the seizure. The seizure just needs to run through its course. Do not attempt to give oral medications, food, or drink during a seizure. The one exception to this would be there is a rescue medication that goes in the buccal membrane or the sublingual membranes in the mouth. And if that's what's recommended for the type of rescue medication for the type of seizures by that specific neurologist, and that would be the exception to that rule. But generally speaking, you don't offer a person something to drink during a seizure because they're at risk for potentially aspirating it. When is a seizure an emergency? If it's the very first time somebody's had a seizure, if the convulsive seizure lasts more than 5 minutes. Now, it could be different based on each individual and what that neurologist thinks is an emergency, but the 5-minute rule is just a general good rule of thumb. If the seizure's getting to be 5 minutes long, it's getting to be a little long. And they're at a little bit greater risk for that seizure not stopping on its own. If a person has repeated seizures without regaining consciousness, I had this happen to me a few months ago. I was with an individual. They were getting their state ID at the DOT station, and as soon as that camera flashed, the person went into a seizure. The person recovered and came back to for 15 to 20 minutes, but then the person started having repeated seizures without regaining consciousness. So we had to call 911. They needed to go to the hospital to be administered some medication through an IV in order to get that seizure to stop. If a person has more seizures than usual or change in type, if the person is injured during that seizure, or if they also have diabetes or they are pregnant, those are conditions where they need to be checked out every time. As I had already mentioned, every time that seizure occurs in the water, you need to call 911. If normal breathing does not resume after a seizure, or if the parent's guardians request emergency evaluation. But always follow the seizure emergency definition and protocol as defined by that neurologist for that specific individual. And it's a good idea to have a seizure action plan. So those are generalized seizures. Now, many people don't realize that over half of all types of seizures are partial seizures. Not many people know that a person can be in a seizure and still be fully conscious. That's what a simple partial seizure is. Full awareness is maintained. And as parents, we did not know that our daughter was having this type of seizure until about a week before a brain surgery. Some symptoms could be rhythmic movements, such as isolated twitching of the arms, face, or legs. Or it could be sensory symptoms, that person describing a tingling feeling with their leg, only guess what? They haven't been sitting on their leg. Or they could be feeling weak in their limbs, or they could be hearing ringing noises in their ears, only there's no ringing noises in that room. They could be smelling a funny smell. They could be smelling, somebody told me the other day that they smelled skunk, only guess what? We were inside a building where there was no skunk around. Somebody could be describing a funny taste in their mouth, only guess what? They just didn't get done eating a meal. Or they could have that feeling of upset stomach or even visual distortions. These are all signs of a potential simple partial seizure. Psychic symptoms, the person could be describing deja vu, hallucinations, or even a sudden fear of feeling or anxiety that they can't explain. Many adults with epilepsy, they call it their funny feelings. I'm getting my funny feelings. I'm getting my funny feelings. Well, for them, that's a simple partial seizure. Another word for a simple partial seizure is an aura, A-U-R-A. And these are things that lead up to prior, and it could generalize to tonicclonic seizures. So people can have two different types of seizures in one event. Now, for this type of seizure, on average, it usually lasts less than 1 minute, but it can be confused with a person acting out, being a mystical experience, or psychosomatic illness. A couple examples I'll give about the seizures with our daughter. She would do this fast, rhythmic hand clapping. And we thought it was one of those autism tendencies. Well, it showed up on the video EEG that it was a simple partial seizure. We were keeping track of all of her seizures, but we had no idea that this hand clapping, fast rhythmic hand clapping, which she did all the time, was a seizure too, because she could walk and she could talk. I was with another individual. We were walking down a hallway. They were painting the walls. And I thought, oh no. Sure enough, that smell from those fumes of the paint was enough to send him into a simple partial seizure. The individual just walked. He wanted to be sat down. There was a secretary at a desk. There was people in the waiting room, and nobody had a clue that that individual was in a seizure. But what really surprised me is for that individual, the person said, I've lost 90% of my vision. I see all colors of the rainbow in front of my face right now. I can't hardly see a thing. But nobody else in the environment knew it. Now, the difference with a simple partial seizure and a complex partial seizure is awareness. The awareness is impaired, and there's the inability for the person to respond. Often, the complex partial seizure begins with a blank, dazed stare. There's a lot of repetitive, purposeless movements. So, for example, if the person is walking and they go into a complex partial seizure, they'll start to walk clumsy or disoriented, just walking aimlessly. If they're sitting down, they could be randomly picking things up, shuffling their papers in front of them, or picking at their clothing, or picking at their neighbor's clothing next to them. Their speech may not be making sense, or there could be some lip smacking going on. Just kind of very odd behaviors. This can last up to 1 to 3 minutes on average. When the person comes out of this event, they're very tired, they have a headache, they're very nauseated. Now, during this type of seizure, this person can become combative. They could get aggressive and start pushing back if they feel like they've been threatened. And this is why we have an education program just for law enforcement, is when somebody's in a complex partial seizure, they don't really remember what happened. Sometimes they can hear what's going on around them. People describe it as like a fog, but they can't respond. People are asking them questions and they can't respond. They have no idea what's going on. So if they feel threatened when they're in that event, it's just a natural reaction for them to push back. It's very unfortunate because what the seizure looks like to the general public and community is it looks like somebody's drunk walking down the street or they're doing drugs. And if they feel threatened with aggressive behavior. Now I'm going to show a couple video clips here on complex partial seizures so you have an idea of what this looks like. I'll pull up the first video clip here.
Another common form of seizure, and one that is not nearly as obvious, is the complex partial. Because only a small part of the brain is affected, a person may still be able to perform gross motor skills, like walking or sitting upright, fully unaware of his or her action.
So I'll show another example here of a complex partial seizure.
Hitting, fending off what, at least momentarily, as a reaction is thought of a
I'll show one more.
I think the most that you would want to do is guide. You don't want to restrict them. You don't want to force them to sit down. That is the last thing you want to do.
So there's various examples of a complex partial seizure. So here's a slide on partial seizures. And so again, when somebody's having a simple partial or a complex partial seizure, it's related to the part of the brain being affected. For example, if somebody has a sensitivity to lights, then that seizure is originating from the back of the brain from the occipital lobe. If the person describes a strange smell or taste, that could be coming from the temporal lobe. If their eyes or head turn to one side, it's from the frontal lobe. And so it's not really important for people to know what part of the brain and what symptoms come from where. But what's important is when you observe the symptoms of somebody in the seizure, that you mark the correct symptoms, because this is a good indicator that it could give to the neurologist, so their seizures could be spreading to different areas of the brain. And this gives them an idea of how to adjust the treatment options. Now, some people have partial autonomic seizures, where the autonomic portion of the brain is affected, which affects the heart rate, the blood pressure, skin temperature, color, sweating, flushing of the eyes. And I just lost my screen again. And our daughter had autonomic seizures, and because of that, we were told that she was at high risk for that sudden unexplained death in epilepsy. All right, we have our screen back. So first aid for complex partial seizure. What do you do if you see somebody in a complex partial seizure? It's very important to stay calm and reassure others. You don't want to be yelling, seizure, seizure. It just brings unnecessary chaos. Track the time. Our daughter had frequent seizures. I wore a watch with a stopwatch feature. I hit start, I would tend to her needs with first aid, and then I'd hit stop, and then I had that time recorded. Do not restrain. You want to gently direct away from hazards, which this can be difficult. If a person's in a room, you want to close the door. The person will take their path of least resistance. But if you're out in the parking lot, kind of like that one video showed, if there's other people around, I would probably have people stand in a circle so that person can wander safely inside that circle. The person often cannot obey verbal instructions when there's type of seizure, so don't expect them to just because they can retain their mobility. It's important to stay with the person until they're fully alert and aware. And again, if it's getting to be hit in 5 minutes, it's getting to be a little long. An emergency protocol should be followed. Intractable epilepsy. What this means is that person has failed to respond to standard seizure medications or other treatment options. They could have underlying structural brain or neurological conditions, and this poses the greatest challenge to achieve seizure control. Status, known as status epilepticus. This is medically defined as 30 minutes of uninterrupted seizure activity, which could be one prolonged seizure that does not end on its own, or multiple seizures without recovery to baseline. This is a medical emergency and requires immediate action to stop the seizure activity. Some doctors recommend a rectal form of rescue medication called Diastat. It's pre-dialed. Others recommend an intranasal spray, and others do a sublingual or buccal rescue medication to stop the seizures. Every person should have a seizure action plan, which should clearly define what constitutes a seizure emergency and a detailed emergency response plan. At the end of these slides, there are links so you can download the seizure action plan from the Epilepsy Foundation, which many organizations and schools use. There's also such a thing as non-epileptic events. Many doctors don't like to call these seizures because it's too confusing. These are events that look like epileptic seizures, but on the EEG monitoring unit, they have no correlation. They have a normal reading. This is also known as psychogenic or pseudo-seizures. And it can be difficult to diagnose, but video EEG monitoring is the most effective way of diagnosing this. A lot of times it's caused by a variety of psychological factors, such as extreme stress or trauma. We see some servicemen coming back from the war experiencing these types of events. And it's important to get a proper diagnosis, because if somebody has non-epileptic spells caused by stress or trauma, the treatment options are different. Seizure medications won't do any good. They need counseling, and they need to find the right counseling to help them overcome that condition. Now, there are several people who have both epileptic seizures and non-epileptic seizures, which is very difficult, because when you look at that seizure to the person's eye, people can't tell the difference. It looks the same. And so that's why the video EEG monitoring is the most effective way of diagnosing this. So an epileptologist, that is a neurologist who has completed a 2-year fellowship in epilepsy or neurophysiology. And so when somebody has uncontrolled seizures, or they have bouts of going into status, they're not already under care of a specialist, they have maybe some other co-occurring conditions such as significant mood or anxiety disturbances, memory, learning deficits, sudden changes in seizure type, signs of medication toxicity or allergy, they failed a couple seizure medications, we recommend families get to an epilepsy expert, an epileptologist. And we do have the list of all the epileptologists in the state of Iowa. Treatment options for epilepsy, we have the first and foremost, we have seizure medications. It's been the best method for controlling seizures, brain surgery, the ketogenic diet, and vagus nerve stimulation. Basically, the seizure medications, there's newer ones out. They're more effective, they have better efficacy, and fewer side effects. More than 50% of people newly diagnosed with epilepsy become seizure-free on medication, and they lead a pretty good life. They have normal IQs, they do well. About 75% of people with epilepsy have seizures that are well controlled by medication, although some people have to do it at higher doses, so they're always balancing the challenge of the potential side effects. So I'm not going to go through these because we're running short on time, but these are the list of some of the potential side effects that could be drug-related to the seizure medication or dose-related to the rate of that seizure medication. There are serious side effects such as a rash, a life-threatening rash, or there's major side effects that are serious, but they're not very common, but they're important to be aware of. So it's important to know the medications your loved one is on or your client consumer is on, and to keep an eye out for those. We talked about rescue medications. The neurologist will prescribe what medication, the details of exactly when it should be given, and specific administration instructions. When people fail 2 to 3 seizure medications, the next line of treatment after failing anti-epileptic drugs is brain surgery. And so the surgical evaluation includes inpatient video EEG monitoring. It could include numerous other tests such as an MRI, SPECT scan, PET scan, and neuropsychological testing. There's various types of procedures. The most common type is the temporal lobectomy. And the reason why the brain surgery is the next choice after seizure medication is because the research has shown once somebody has failed 2 to 3 seizure medications, it's not very likely they're ever going to get control on seizure medications. Although that's tend to vary with some of these newer ones out in the market where people are able to get control when they failed numerous others. But for temporal lobectomy, a lot of doctors have patients that have a 70% likelihood of getting seizure freedom. But the post-surgical seizure-free rates vary depending on the person, the etiology of their seizures. Some patients go home after a short stay in the hospital, or others could miss several weeks of work or school. Here's an example of an MRI where a basic resection was done. They took out the part of the brain where the seizures were originating from, and then it just fills up. See that black space? It just fills up with cerebral spinal fluid. Now this is a picture of my daughter's MRI. She needed a hemispherectomy, and she had the right half of her brain removed about 5 years ago. So you can see this MRI is from 6 months post-op. The right side just fills up with fluid. And this one was from a year ago. This is the third and left lateral ventricle, and you can see this is hydrocephalus. She has increased fluid in these ventricles, and so we're monitoring for hydrocephalus, but no clinical symptoms. The ketogenic diet, this is a diet based on finding that burning fat for energy has an anti-seizure effect. It's used primarily to treat severe childhood epilepsy that has not responded to standard seizure medications. It's not a healthy diet, but the diet includes high fat, no sugar, low carbs, and low protein. It requires a very strong family, school, and caregiver commitment. If the child sneaks one Cheerio, just one Cheerio, it throws the whole diet off. It is a medical treatment, and it's not a bad treatment. But there are numerous families that have gotten complete seizure freedom on this diet when nothing else has worked. It's just very, very rigorous diet. The vagus nerve stimulator, this is used as an option. It's not sold as a product to control seizures. It's sold to decrease the frequency and severity of seizures when none of the other treatment options have worked. It's a device planted just under the skin in the chest, and the wires coil around the vagus nerve up in the neck, and it delivers different electrical stimulation, different blasts to the brain to just kind of break up those abnormal brain waves. It's used primarily to treat partial seizures when medication is not effective, although some of the newer research shows it can treat all seizure types. Not treat as in control, but as far as decreasing the severity and frequency. There's a special magnet a person uses they swipe it over that spot where the battery was implanted. And many times when I swipe it on individuals, it stops the seizure. Or a lot of adults say it shortens the recovery time. They can go right back to work or right back to school. So these are what the batteries look like that are implanted. It's a very quick surgery. They're in and out the same day. This is what the battery looks like. Individuals can request extra batteries from the neurologist for free, or extra magnets. So you can have one at your agency, you can have one at school. So just have the family ask the neurologist for extra magnets. But basically what you do, you just swipe the magnet. You swipe it once, and you wait for the seizure to subside. But if the seizure is still pretty intense, you wait 1 minute and you can swipe it again. Now, when somebody just gets a new VNS implanted, it takes a while for it to get to a high enough setting. And so when they get it put in, it's turned off. Then they see the neurologist and they turn it on. Then they go back in 2 to 3 weeks later and they turn it on to a low setting. And they go back every few weeks and they slowly increase the setting. It's pretty neat. The neurologists have a device they can put over the top of it, and they can tell how many times that magnet's been swiped or how many times they're having seizures or getting those funny feelings. Now, the biggest side effect people see is that their voice gets high pitched when that magnet kicks, when it kicks on. And so what happens is when you swipe the magnet, it just kicks on to break up those abnormal brain waves. It's one of these things they really don't know how it works, but they do know it helps decrease the intensity and severity in a lot of seizures in people. It's important to know that seizures affect learning, behavior, psychosocial development, overall quality of life. It could be the seizures itself, the medication side effects, it could be the underlying brain abnormalities, co-occurring conditions, or even attitudes, beliefs, and experiences. People with uncontrolled seizures have difficulty with learning, memory, concentration, and attention. After a seizure, work may have to be retaught. This was often happened with our daughter, is the teacher would say they would teach her instructions, she would have a seizure, she would sleep for a couple hours in the nurse's office, she'd come back, and they'd have to reteach her everything all over again because everything was wiped out from that morning. Learning problems can persist even after seizures have been controlled. And so some kids are on an IEP. Other kids, like I said, have a completely normal IQ and do pretty well. Medications, it's important to know, may cause drowsiness, inattention, concentration difficulties, and behavior changes. Our daughter was actually on 4 seizure medications at a time and became toxic on it, and we didn't know it. She was having a ton of behaviors. We actually enrolled her in the CDD behavior clinic, all-day clinic. At the end of the day, we walked across the street to the neurologist. The neurologist said, well, why didn't you tell me? She's clearly toxic on this medication. They titrated her down on 2 of the meds, and within 2 weeks, her behaviors improved immensely. When they slowly increase these rates, you just don't know because it's such a gradual thing. It's also important for you to know that people with epilepsy are more likely to suffer from low self-esteem. People are very fearful, not knowing when and if that seizure is going to occur. And so we tend to see a lot of depression in people with uncontrolled seizures. So, their self-image, their self-confidence, low self-esteem, anxiety, depression, delayed social development. Some people benefit from counseling, especially teenagers and young adults. They don't like the side effects of the medication, so oftentimes it's hard to get them to comply with taking their medication on time and every time. And this is one of the reasons why we started an Iowa Epilepsy Youth Council, to build that support network with teens and young adults in the state of Iowa. So there's all sorts of things to think about. These are the links for helpful record keeping. And this is what a questionnaire for a parent of a student with seizures. And this is very nice to provide the school, the agency, or the group home. It just gives them an idea of what their day when their seizures are occurring, what their potential triggers are. This is what the Epilepsy Foundation Seizure Action Plan looks like. A lot of people choose to use this, and they have their doctors sign off on it. And so that way, when there's an emergency, they know what the protocol is to help keep your loved one safe. And this is the seizure observation record. A lot of people like to use this because it doesn't involve a lot of writing. It's just a checklist. Did you see the head turn? Did the person fall down? Did the right arm jerk? Did the left arm jerk? And so if anybody witnesses a seizure, you just check off on that checklist, and then your agency or your school has a copy, and then you give a copy to the parent or caregiver so they can share with the neurologist. And so all the video clips that I showed today are from the Epilepsy Foundation's video called Understanding and Assisting People with Epilepsy, which is also found on the Epilepsy Foundation YouTube page on the following link. And I'm Roxanne Cogil with the Epilepsy Foundation. I have our websites. There's numerous resources on our websites below. And we provide free seizure trainings to any group in the state of Iowa that needs them, to group homes, nursing homes, daycare centers, schools, you name it. And we also have support groups across the state. We have the Iowa Epilepsy Youth Council. We have a spring conference coming up on March 1st in Des Moines, the statewide epilepsy conference. We're going to have 2 epilepsy walks this spring. We're going to be starting 3 art therapy programs, one with the University of Iowa, another one in Iowa City, and another one in Des Moines this spring, where people with epilepsy can work their emotions through art. So I encourage you to have your loved ones call in to me. I'll walk them through some of their challenges, help guide them to resources to help improve the quality of life, and we just try to do everything we can here at the Epilepsy Foundation to help individuals and families have a better life living with their seizure disorder and epilepsy.
Okay, thank you so much, Roxanne. I do have some questions that came in. I appreciate there at the end, there were several people that asked how they could get some more training from you for their staff. So I just want to point out again that if you feel like you and your team or your agency might benefit from hearing more from Roxanne, please note that her contact information should be there on the screen and you can contact her. If you're a family of a loved one, please make sure that you're reaching out as well. She's a great resource for information, and I know that she'll be glad to lead you in various directions that will be helpful.
Yes, my phone number is 515-238-7660. That's my work cell phone, and my email is listed on that slide. So.
And then we do plan on sending out a copy of the PowerPoint for folks, and the webinar will be archived on our website. We do have a couple of questions here. One was about the diet programs that you talked about, asking whether or not you use that for your daughter, and talking a little bit further about the different types of diets that people may want to use. Do you use that in your household?
Well, the medical diets to help control seizures, we did not. We were told because of our daughter's brain abnormalities, it wasn't an option for her. But there's the ketogenic diet, which I had talked about briefly, the low glycemic diet, the modified Atkins diet. Those are kind of the three diets that epileptologists will occasionally look at to see if it would benefit in seizure control for certain individuals with epilepsy, mostly children. And so the only epileptologist in the state of Iowa that we only have one level 4 comprehensive epilepsy center in the state of Iowa, and that's the University of Iowa. So Dr. Joshi does the diet, and then they hired a new pediatric epileptologist a few months ago, Dr. Michael Siliberto, can do the diet as well.
Okay. And there was another question in regards to if somebody is using medication for seizure as a PRN as needed, but it's also the same medication that they take for anxiety. Is there any concern, or should they have concern of their body building up a tolerance to that?
Well, I'm not a medical professional, but there's a couple things. Some of these seizure medications are used for other purposes. Lyrica, for example, also has an indication for pain management. Topamax is used for migraines. So people are using these medications for other conditions that have nothing to do with seizures and epilepsy. The other thing regarding anxiety is some of those, well, it's important for the doctors to know if there's going to be a potential interaction with seizure medication. Now, for example, with my daughter, she has focus and attention challenges. When we asked about medication for that, they said it took so long and hard to get her complete seizure control that it wasn't worth the risk, because the one that they needed to put her on would lower the seizure threshold, and that wasn't a risk we were willing to take, or they were willing to take. So those questions are best answered by those medical professionals.
Sure, sure. And I think the other questions, for the most part, were answered within the rest of your presentation. I think I'll take a look through them again and answer other ones by email as appropriate with you, Roxanne. So thank you very much, everyone, for attending. We appreciate you joining us today. Roxanne, thank you very much. We very much appreciate your knowledge in this area and joining us today as well.
You bet. I do have a 60-second video clip of my daughter dancing if anybody would like to see what a child with a hemispherectomy, how much they can do with that type of brain injury.
Absolutely. Why don't we end with that clip today?
If I could pull it up here. She was in a Miss Amazing pageant in Council Bluffs last February and chose to do this short dance as her talent. So it's just, here's a girl who had a ton of behavior problems, ton of challenges, brain injuries they couldn't identify of when and how it occurred. But there's just a lot of hope out there, folks. You could be given the worst diagnosis, the worst hope, whatever, but medicine's changing. There's always new improvements. We were told we would always have to live with the seizures, and now we have a girl, even though she's left with half a brain, she's so much better now on a good half versus having that bad half drag her whole brain down. So never give up, and call in and ask questions, and we'll try to help as best as that we can.
All right. Well, thank you so much, Roxanne, for that. Have a great day.
All right. Thank you, everybody.